Well, hello. Thank you very much, Dr. Dunn, for the introduction, and Julie for all your hard work and your tireless work in the province. It's really appreciated, and I know we're all proud to know you personally too. So we've got to switch gears and talk about infertility diagnosis and testing. As a disclosure, I have nothing. We will talk a little bit about the definitions of infertility, when to investigate, how to investigate, and some of the potential causes, including age and infertility's impact from it. And then also a little bit on how to treat unexplained infertility. So what is infertility? Well, we generally define it as a failure to achieve a pregnancy within 12 months of trying, and about 15% of couples will fall into that mix. And it's important to note that these statistics are based just on couples that are not using any contraception, so it's not necessarily on couples that are actively trying. And what's also interesting is that this is a really front-end loaded phenomena. So if couples don't conceive after the first months of trying, their chances of obtaining a pregnancy do drop. In fact, about 60% of couples will be pregnant in the first month, 3 months of trying. And this is just a graphical representation of the same idea, which is that at about a year of trying, 85% of couples not practicing contraception will in fact be pregnant. And you can see between year 1 and year 2, it's just a small increment, about 8-9% of couples that will fall pregnant at that point of 2 years. So timing of intercourse, so frequency of intercourse has been studied. We often recommend every second day, but in fact, the statistical difference of conception between every day and every second day doesn't seem to be present. And of course, if it's less often, then chances of conception do go down. Abstinence can also have a negative impact on sperm. And so it appears that every day or every second day would be the best times to try during the normal menstrual cycle. Coital practice, it's a question we get a lot, what position affects fertilizability, and there is no position. Sperm can be found within the cervical canal in about 90 seconds, fallopian tube within minutes. And that's done by studies using sperm that are labeled by technetium 99M and then doing scintigraphy to find that out. Yeah, you probably should wear a face mask, I guess, with your couples having intercourse, but that's a personal thing, of course. I just wanted to point out that topic number 2 is how to increase your semen. I don't really know what that is, but it was very well done. Coital practice. So, the fertility window seems to be somewhere between roughly 5 days before ovulation to a day after. And then the window seems to extend up to 6 days. But the real probability of pregnancy by cycle days is from day 1 before ovulation to day 3 before ovulation. And remember that those LH surges will predate ovulation by about 36 hours, which is a good thing. It gives us that predictive value. How do you detect ovulation? Well, there's all sorts of ways. You can use a calendar, and the corpus luteum will last about 12 to 14 days, about 13 and a half days on average before a menstrual cycle starts. So you just count backwards. Apps are basically a glorified calendar. So they're an online calendar that's pushed to people's phones. And I'd say 95% of our patients now use an app to track their periods. Basal body temperature, you have to use a digital thermometer. And of course, it's after the fact, if you remember. So that temperature rise won't happen until ovulation occurs. Ovulation predictor kits are highly useful. Egg white, cervical mucus, and middle schmerz. So some people can feel that rapid expansion of a follicle just prior to ovulation. And then, of course, demonstrating ovulation through the use of LH and particularly progesterone testing in the luteal phase is another method. These are all the various methods. Again, an app. A lot of people use these urine predictor kits, and they all work in the very same principle. So don't encourage them to buy the most expensive ones. They all work very much the same way. Temperature charting, it was used a lot in the past. People still do temperature tracking. There are various devices, including earbuds and the Apple Watch, that will track temperature differences. I just always tell my patients, once they've documented a few cycles, to throw these charts away. They're very frustrating, and they're a constant reminder of failure. So it's a good idea to document it if they can, using temperature or ovulation kits. Another way to detect if you're ovulating is to read this great article by my partner, Dr. Dunn. The QR code's there if you want to scan it, but Dr. Dunn writes a lot about basic fertility, and this is an excellent article to give to your patients to teach them how to check ovulation. So when's a good time to start getting professional help? Well, per that chart that I put up, if couples that where the female partner's under 35 have been trying for about a year, that's a good time to start. About 15% of couples will be in that arena. If you're over 35, because of the risks of aneuploidy and also the decreased likelihoods of conceiving, probably after 6 months is a good idea to start seeking professional help. And over 40, because of all those risks getting bigger, it's probably good to seek help right away. Irregular cycles are another reason why you would get a referral. So the average person has about 12 or 13 times a year to conceive. So anything that will drop that number, i.e. periods that are 45 days apart or very irregular cycles, would be a reason to refer. And of course, other findings like PCOS, other endocrine disease, uterine pathology that's been documented. Anyone with a risk factor for tubal disease, so if they've had serious pelvic inflammatory disease or had a prior ectopic pregnancy or pelvic surgery, endometriosis, probably should be referred earlier than later. And of course, male factor, infertility with a prior partner or erectile ejaculatory dysfunction would all fall into that. And of course, same-sex couples or single people trying to conceive. So how do we investigate? So of course, this is the three-legged stool: sperm, anatomy, and eggs. I always tell my patients this is, grade 5 body science. And the very first thing we'll talk about is sperm. So how do you investigate sperm? Very, very simple, through a semen analysis, best done about 2 to 5 days after abstinence. If you have a hard time going to sleep tonight, just download the WHO 5th edition for the semen analysis prep. It's very long and very boring, but essentially it's been determined over many, many years through looking at human sperm what the minimum effective concentrations are and motility to achieve pregnancy. One quick warning about time to process: sometimes we'll see sperm analyses where it's taken 180, 220, 240 minutes to analyze. And, by that time, the semen has kind of become one with the specimen jar. So the sooner it's processed, the better. Morphology, it's a referral we get a lot for, which is abnormal morphology. And morphology is a very difficult thing to reproduce. It has very poor inter and intra observer variability and consistency. So the most important thing about a semen analysis really is the concentration and the motility. Morphology is of less importance, but if we see prolonged infertility or patients with poor motility, then morphology does become important. Morphology seems to be on the rise. 20 years ago, 85% was considered the normal. Now the bare minimum is 4%. And that's probably due to just more strict application of the criteria or possibly a negative environmental influence. Testing for semen analysis can be done at life labs or in infertility clinics like ours. We often do very advanced sperm testing like antibody screening, sperm functional assessments where we do a trial wash to see if people could be successful with IUI. Morphology assessment where we look specifically at, where the morphology defect is. And because assessing sperm is so easy, we usually don't subject a female partner to invasive testing without first getting the male semen analysis documented. So other investigations, so anatomy. Of course, it's important to ask about dynamics of intercourse. Patients don't generally volunteer intercourse issues unless you ask about it. But we do then focus on anatomy and tubal patency. The best possible test really is hysterosalpingography. Image on the left shows a normal appearing uterus with thin fallopian tubes on each side, and the image on the right shows a collection of contrast in the fallopian tube, indicating hydrosalpinx and tubal obstruction. The HSG is very good sensitivity and specificity for fallopian tube pathology, but it is less accurate when it comes to endometrial lesions. So if there's something in the lining, either a polyp or a suspicion of a fibroid, saline-infused sonography or sonohysterography or hysteroscopy referral would be indicated. One quick note: if you order an HSG and someone's got a risk factor for hydrosalpinx or previous PID, starting them on antibiotics ahead of time is a good idea. It's not definitely a routine. or if the radiology clinics detects hydrosalpinx, they often will put the patient on prophylactic measures of antibiotics. This is just an example of a possible bicornuate or septate uterus that can be picked up on HSG. Both oil and water-based contrasts may shorten the time to conceive. It's not intended as a treatment, but it does seem to have an impact on fertility. If you see any anomalies, of course, moving on to MRI, sometimes with 3D ultrasound or laparoscopy, hysteroscopy, and 3D ultrasound is one of those things that we often provide in our center. My slides will be posted, but these are the phone numbers for some of the different places that you can access HSG to get done. Pelvic ultrasound is a useful tool. It's helpful if other symptomatology is present, like pelvic pain. It's very helpful to rule out things like myomas or polyps or even endometriomas, but it's not a necessary tool. We often do it as part of our first consultation. And the last is eggs, and it's really hard to test eggs. And there are two vital aspects of eggs. Of course, their quantity and their quality. Both are unfortunately affected by age. And this is one thing that society is progressing towards. Women are choosing to have children later in life. In fact, in BC, we have the highest age of first birth in the country. And 2010, 10 years ago, was the first time in history that more women are choosing to have children in their 30s. And there are three costs of this age impact. One is an increased chance of aneuploidy, miscarriage, and of course, infertility. In this graph, you can see that there's been a progressive decline in the women having children between age 20 and 34, and an increase to 23% in those having children over age 35. So don't forget, with aneuploidy, it's very much an age-based risk. So when you're under 35, the chance that there's oocyte aneuploidy is about 15 to 20%. And as you can see, as you get older, particularly over age 40, the chance is 40 to 50%, over age 45, 80 to 90%, which is why pregnancy is so rare. Eggs and oocyte aneuploidy, this is a study by Fernasiak that just showed that between the ages of 35 and 41, there's about a 50% drop in chromosomal competency. The other consideration that we often see is patients that come to see us in their mid or late 30s and potentially are seeking 2 or 3 children will have some troubles. And with diminished ovarian reserve, the likelihoods of achieving a second or a third pregnancy may be very diminished. So that's one conversation we often have with patients, which is what's the size of family you want, and that can sometimes govern what treatment they choose. So what is ovarian reserve? Well, technically it's the number of eggs that are left in the ovary. And we test functional ovarian reserve by looking at the hormonal response between the pre and antral follicles. And that's really a true measure of egg reserve. So people are born with a certain number of eggs, generally at birth about 1 to 2 million. By the time that puberty happens, it's about 400,000. And it's estimated that about 1,000 eggs are recruited every month at the time of first menstruation for one to ovulate. And that number declines over time. So that means the average woman loses about 16 to 30 eggs per day. By the time of menopause, there's only about 1,000 eggs remaining. So this curve may also be shifted downwards in some people. Either they start with less or they run through more eggs every month. And that's why some people will have a very low egg reserve in their 30s. It's not related to overall gravida or oral contraceptive use. The decline is very significant after age 35, and that intersects with the number of people that are trying to get pregnant now after age 30. So how do you test it? There are some good tests. Day 3 follicle stimulating hormone is been used for a long time. Anti-Mullerian hormone, which I'll talk about, is relatively new, as well as antral follicle count. Antral follicle count, very simple, is just looking directly at the ovaries. So day 3, if you recall, from endocrine is produced by the anterior pituitary, and it acts directly on granulosa cells for ovarian egg recruitment. It can be suppressed by estrogen. So if you see people with high estrogen levels, that FSH can be low. And so that's why we do an estrogen level at the same time. Now, as FSHs creep up, there's a lower chance of getting pregnant and therefore a lower ovarian reserve. So we get concerned when a day 3 FSH is over 12. Anti-Mullerian hormone, slightly new, harder to measure, secreted in very small amounts. And in the last 5 to 7 years, we've got some very good lab platforms to help us determine AMH. It is produced by granulosa cells and therefore is directly related to the number of eggs in the ovary, and is very stable across the menstrual cycle or when on the birth control pill. So it's become a very, very good test for us as fertility doctors. This is just a graphical representation of how AMH is recruited. And again, it's a very direct relation to the number of eggs in the ovaries. Life Labs in BC is about a $70 charge to direct to patients, and Alberta is paid for by Alberta Healthcare Insurance. Again, any day of the menstrual cycle. The normal range is highly age specific. The higher the AMH is, the more eggs a person has. It can be, though, artificially high in conditions like polycystic ovarian syndrome. Generally, when it's low, we expect lower eggs to be seen, and that pans out true during egg retrieval. Very useful for us for dose planning during IVF or ovarian assessment, for instance, with infertility or after chemotherapy, or trying to confirm menopause or perimenopause. So then, the last thing is unexplained infertility, which is a common thing that we see. About 10 to 30% of couples, we won't find an identifiable cause, and we're not sure why that is. We tend to think that it's an intersection between both eggs and sperm or anatomy. As an example, tubes might be open at HSG, but do we know that the cilia are functional? That's one example of functional or unexplained infertility. How do you treat it? Well, we generally treat it very empirically, either make more eggs or get sperm closer to those eggs. And that can be accomplished through using oral or injectable superovulation, and sometimes through IUI, where we wash sperm and place the purified sample into the womb at the day of the detected LH surge, or both. And lastly, IVF would be an option. I just want to quickly review that evidence. So IUI alone, not a very good treatment. So there's actually only one RCT that evaluated IUI alone versus expectant management, and the pregnancy rate wasn't significant. It was higher than the spontaneous group, but not a significant amount. Clomiphene citrate or letrozole alone, many studies as well, but it appears that there's no real benefit to using either of those ovulation induction agents alone. And letrozole and clomiphene seem to be very much in parallel without significance in their benefit. Clomiphene or letrozole with IUI may have a role. There are 2 randomized trials comparing clomiphene IUI and letrozole IUI, and they both seem to give about an 18 to 19% likelihood of success. The largest trial, the Amigos trial, demonstrated for women, and this was in a group of women that were average age 32 with 3 years of infertility, that the clomid group gave a pregnancy rate of about 6% per month, and letrozole gave about 7.3% per month. So oral agents with IUI are reasonable options to consider versus just expectant management alone. Gonadotropins, the big risk with injectable drugs and IUI is that of multifetal pregnancy. And in the Amigos trial, the cumulative live birth rate was higher, but with a significantly higher risk of multifetal gestation. So much so that the NICE group in the UK have advised against the use of FSH and IUI due to that risk of multifetal pregnancy. IVF, of course, provides a drastic reduction in the risk of a higher order multifetal pregnancy. The recent Quebec experience and our current Ontario experience is evidence of that, where the mandated policy of single embryo transfer almost virtually eliminates multifetal pregnancy. Costs, of course, are a barrier, but it is probably the best first-line treatment for unexplained infertility. IVF, as most of you know, involves some time of oral contraceptive suppression, followed by the use of injectable gonadotropins for about 7 to 11 days. We then do egg retrieval and embryo transfer. And for couples where there might be advanced maternal age, we often offer pre-implantation genetic testing, where we do embryo biopsy to allow for the detection of aneuploidy or other genetic issues. Success rates are much higher than the non-IVF treatments. These are cumulative success rates from our center, but in the group under age 35, we look at about 76% likelihood of achieving a pregnancy. Lastly, I think it's important to have a conversation with your patients about the impact of age and fertility. They're affected by the media and a lot of stars that get pregnant in their late 40s or early 50s, which are all largely through the use of donor egg. It's important to educate our patients when they're younger. And of course, investigate when a patient's under age 35 after a year of trying, a little sooner, 6 months after age 35, and even sooner if they're over age 40. If there are other issues like ovulation or male factor issues, refer immediately. The basic evaluation that you can do would include a day 3 FSH and estradiol, an AMH level, an HSG, and a semen analysis. And our referral model, you don't have to do any of those things. Our referral coordinator will coordinate all of that testing if it's required. But if you do wish to do some testing, those would be the 4 basic things to organize. Other quick points: clomiphene or letrozole alone is not likely an effective treatment for unexplained infertility. Clomiphene and letrozole with IUI has a modest effect. There are dangers of recombinant FSH with IUI, and really the IVF is considered to be the best treatment for unexplained infertility. And this is just a link by QR to a really good paper, again, by Dr. Dunn on the subject of diagnosis and testing, just for a quick pocket reference. So if there are any questions, be happy to take them at this point.
All right, we have a question here. Do we always need HSG before trying letrozole in primary care? Would it be reasonable to try letrozole for 1 to 3 cycles if their risk for tubal occlusion is low?
Yeah, I would say it's very reasonable to try letrozole for 3 cycles. The risk profile is quite low. And as long as the patient's aware that there may be other things than ovulation that are causing an issue, certainly in patients that have irregular cycles, attempting letrozole right away, cycle day 3 through 7, escalating doses from 2.5 to 7.5 milligrams are very reasonable to start with. And you're absolutely right. After 3 months of trying that, if there's no benefit, I would move on to further investigations.
Okay, another question. What to do when Life Labs consistently have prolonged transit time over 100 minutes for semen analysis specimen, which makes results unreliable despite multiple complaints?
Yeah, that's tough. Our patients get very frustrated by that. Most of them will just do their semen analyses here. We do a far more combined sperm assessment than Life Labs does. And we book those assessments. There are 2 private rooms on site where our male patients will produce the sample. Our scientists are waiting right there to, well, not in the room, but outside the room to receive the sample and process it right away. And we get very, very robust results from our analyses that we do here.
And our last question, when is SA concerning? There are many AVN noted on results, likely due to delayed testing time.
Yeah, the delayed testing time will be an issue and will definitely skew your results. We do get worried with low concentration, low motility. Dr. Wu is going to give us a full rundown on that a little bit later, so I don't want to steal any thunder from him.
All right, sorry, if I can squeeze one more in. Is AMH testing more of a useful test for IVF?
AMH has really been helpful for us. In the patient with unestablished fertility, it's hard to interpret, but it is a very good tool to help educate patients. Most of our patients are in their 30s. And if we see a drop in their AMH and they're planning a larger family, at least we can counsel them better about how to do that. For instance, patients with low AMH should probably think about going directly